So welcome back, everybody, to our panel discussion. We have three panelists joining us. We have Carissa McEachern, who's online as well. We have Dr. Rosie Stenhouse, who's online, and Dr. Victoria Smye. What we're going to do is give each panelist about approximately 20 minutes to do their individual presentation, and then we're going to do the introductions and the presentations just back to back to back in that format. At the end, then we can have a panel Q&A or a group Q&A and discussion on any of the content that was presented by our panelists. So first up, we have Dr. Rosie Stenhouse, who's going to be presenting, doing a presentation titled Skills and Resources for Well-Being, Being While Navigating Complex Professional and Organizational Issues. Dr. Stenhouse qualified as a mental health nurse in 1992 and has worked across inpatient, community, and NGO settings. She is currently a senior lecturer and head of nursing studies in the School of Health and Social Science at the University of Edinburgh, as well as a visiting assistant professor in the Faculty of Health Sciences at the University of Maribor in Slovenia. Her mental health teaching draws on social science, arts, humanities, to engage students with service user experience and consider the complexity of mental health related experiences in the social, cultural, and political contexts of people's lives. A strong thread of social justice drives her research and current projects, which include leading on issues around ethical engagement for the Realities Project, which is a large project focused on improving people's experiences of community-based health and social care systems in Scotland. Also leading a research capacity building project in Ghana focused on healthcare professionals and academics, and involvement in the project focused on developing a system for psychosocial support for young people who've experienced stroke. So welcome, Rosie, to the Education Day. I'll turn it over to you.
So thank you anyway for inviting me to speak. It's a real honour to join you on your Mental Health Nurses Day. And my presentation, as Dawn says, is going to focus on skills and resources for wellbeing, while navigating some of the issues that I'm going to also then draw out, which I think create the capacity for burnout. So I'm going to start by thinking about, are these slides big enough? Can you see the writing? Can you read the slides? I'm just worrying that it looks quite small to me. Well, I'll carry on. If you can't read the slides, if somebody would just tell me, I can't see you, so it would be really useful if somebody just tells me. So I'm going to start anyway by thinking about these challenges that mental health nurses negotiate. And I'm going to think about three particular areas. So discursive tensions in the mental health system, the mental health nursing and nature of mental health nursing and emotional labour, and then organisational issues. And I'm going to then talk about possible ways forward, so the resources and skills that we might develop at the level of the individual organisation, and then sort of policy, government and force. But I thought it would be really useful to think about actually what is the issue? What are we talking about? Why is self-care and looking after ourselves and mental health nurses' well-being, why is this an issue that we need to attend to? And for me, I guess ultimately the issue becomes burnout and actually then loss of nurses to our profession and to our healthcare systems. And burnout is something which is identified in various systematic reviews, and I've put data here from Lopez and Lopez, whose meta-analysis identified that the three different aspects of burnout, that emotional exhaustion was 25% and low personal accomplishment were 22%. So these are quite high rates of aspects of burnout that people are experiencing. And Tang and colleagues in their work found a significant correlation between perceived organisational support and burnout. And that becomes particularly useful to think about when we're thinking about what organisations in particular might do to support their staff and improve the situation. So the first challenge that I'll briefly identify is one that grows out of the history of our mental health systems. And I'm assuming to some extent that the UK history of mental health and psychiatric systems is somewhat similar to that of your own psychiatric systems. And so historically, psychiatric systems primarily operated a population management function, separating the MAD from the rest of the population through, at sort of some point in the 1800s, the admission to asylums, which were defined as total institutions by Goffman and still continued to exist well into the late 1900s. So, you know, the last institution in Scotland closed in the 1990s. And these total institutions, which were identified by Goffman in the 1960s, had these impermeable boundaries, meaning that there was little or no interaction with the communities in which these institutions were situated. And the purpose of these institutions was risk management, primarily the management of risk to the population. And nurses, they weren't generally called nurses then, they were often called attendants, who worked in the asylums, were contextually situated in this discourse, and nursing as such was focused on physical management of patients or inmates. And we can see here, I put a picture of the film made of Ken Kesey's One Flew Over the Cuckoo's Nest as something that probably we all recognise as an example of that period. Oh. And then if we move forward to our present systems, we find that the primary discourses are those of recovery. And here you can see a picture of Pat Deegan, who's one of the key sort of founders, I suppose, of this concept, and therapeutic relationships. And this discourse positions nurses as working with patients through therapeutic person-centered relationships towards patients' realisation of their potential. Quite a different discourse from that of management of a population and segregation, and a very different discourse to that even of 30 years ago when I trained. However, whilst we talk now of recovery and think in terms of therapeutic relationships, the traces of the discourse of risk are still evident in the function of the mental health system, which continues to function in a protecting way, protecting the population from those who are identified as having mental disorder or mental illness. And so that function remains. And it's operationalised through our mental health acts. And the key point here is really that despite the shifts in mental health discourse from one of explicit population management to one of therapeutic intent, the population or risk management discourse remains, albeit less foregrounded. And this means that as nurses, as mental health nurses, we are working in a context where we are both looking to work in partnership with people, listen to their stories, their hopes, plan with them how they might attain some of these, and thinking about these same people in terms of risk, such that we're constantly watching and assessing for signs that we might need to act to manage that risk. And this need, I think, to work between these two opposing discourses creates dissonance for us, and it poses significant ethical and therefore emotional challenges. So that's one set of challenges posed by these sort of institutional discourses, if you like. And then the next challenge that I identify is the extensive emotional labour required by the work that mental health nurses do nowadays to manage these therapeutic relationships, which are central to our role. And emotional labour, a concept identified by Hochschild in the 1980s, involves the nurse in the management of their own emotional state, for instance, suppressing emotions or acting in a way that's incongruent with their inner emotional state, in order to produce that required emotional state in patients and arguably also their families. And this work is mostly invisible, and yet it can be intense and leave the nurse emotionally exhausted. And studies have identified that where there's no action to support the nurse to recover from this emotional labour, that this can lead to burnout. So again, here we have something that's central to our role, that's invisible, and that if not attended to, if we don't get support, then it can create issues of burnout as well, with the consequences for the profession. And then organisational issues, so lack of human resource, poor working environments. So the balance of work demands versus resource, the amount of control that nurses experience of their work environment, of their workload, their role clarity, the level of support that's available to them, all contribute, as does bullying and harassment. And the evidence would tell us that bullying and harassment exists, you know, across the nurse workforce, but that nurses and healthcare practitioners who belong to minoritized groups, and particularly Black and minority ethnic groups, experience increased levels of bullying and harassment. We then have issues with poor work-life balance, which are exacerbated by long shifts, and here I'm thinking about sort of 13-hour shifts, but also within the UK, certainly rotational shifts. So going from these long day shifts to then doing night shifts and back onto day shifts, and sometimes that occurs within a single week. Low rates of pay and presenteeism. So these are all factors which are organisational factors which feed into the burnout that's experienced by nurses. So then thinking about what might we do about this, and I don't have any kind of magic wand. It's interesting. I listen to the other presentations and I think, oh yeah, I'm going to say that and I'm going to say that. And I think nothing that I'm going to say will be new to you. Nothing that I'm going to suggest will be new to you. I think one of the things I would say, though, is that I absolutely don't believe that the responsibility for dealing with the burnout crisis rests with individuals. I wonder about the ethics of requiring individuals to change their lifestyle, develop skills, resources to enable them to be more resilient and continue to work within a system which places increasing amounts of pressure on them and doesn't provide support. So I think there are ethical issues about the sort of quite neoliberalist argument that actually it's about individuals developing their resilience. However, there are things that we can do at an individual level, as long as these are then considered in the round with other organisational and policy level actions as well, which I think are really important and which also speak to the complexity of the issues that cause the burnout in the first place. And so one of the things I think we can do when we're thinking about emotional labour is kind of surfacing that prevalence of emotional labour. So making it visible, talking about it, recognising it, making it all right to speak about. And so here we start to sort of see the crossover between individual level actions and organisational actions, as there is a responsibility on leaders within clinical areas and within clinical services to develop safe spaces which enable people to then be able to talk about the emotional impact of their work in a safe environment. Developing increased emotional awareness and emotion management skills, again, can be really useful. A lot of the time we are experiencing our work, we're just getting on with our work. We're not necessarily thinking about the impact of that work emotionally on us. And so it can be really useful to start to track that impact. And I've put here on the right-hand side of the slide, you know, we can use sort of CBT type diary approaches to begin to really unpick some of our emotional experiences and work. So thinking about, you know, the emotion that occurs, but then what was happening? So what was the event that occurred that this emotion is attached to? What kind of thoughts were there around about that? What action, physical reaction and action did you have? And then in a sort of CBT way, thinking about, okay, so this was this series of events. How might I change that a little bit? You know, how might I change the actions that occur in this situation? Clinical supervision, I think we probably all have worked in services, I would imagine, where clinical supervision takes, you know, is available in some form or other. it has come in and gone out of fashion, I suspect, over the years, certainly over the 30 odd years that I've been practicing. And it can take individual form, it can take group form. I think the important thing with clinical supervision is that, again, that it develops that safe space where you are not, where there's not going to be any comeback, I guess, for making yourself vulnerable as a clinician and talking about difficult situations, so that then it's effective in enabling you to process and engage with and understand the impact of your work. And likewise, there was a discussion earlier about sort of the debriefing, and debriefs after sort of critical incidents particularly is really, really useful as well. And then something that I've become more aware of, but I guess the mindfulness movement has been around for a very long time, but kind of an embodied engagement with emotions. If we think that, if we follow some of the theoretical work and the neurobiological work, thinking about emotions and the body and how emotion, and usually talking about it in terms of trauma, but then actually we could consider some of the continual stresses that we experience as traumas, particularly given the dissonance that it may create. And these are held in the body. And people like Peter Levine, for instance, who's developed somatic experiencing, which one of my PhD students is using with ICU and A&E nurses, looking at their ability to take the skills related to that to manage their emotional experience during sort of critical situations in the clinical area, is certainly sort of making me think about the potential for ways, embodied ways of exploring this as well. So for those of you who are interested, you might be interested in looking further at that. Breathing, in the moment, in the situation we're in, taking a deep breath into our stomach, gets rid of some of the tension, can ground us in times when actually our autonomic nervous system is becoming aroused, and we need to gain some control of that. And then we will all have at times come across the advice for and the huge amount of evidence in relation to diet and sleep and exercise, and sort of work-life balance, and the fact that we should be thinking about all of these things, and yet actually often the structures which exist within organisations make that really difficult. I've already talked about, for instance, the shift structure. So how does that impact people's sleep? How does that impact people's ability to exercise or to have a nutritional diet, or actually to socialise and have social time as well? So this again is where the individual level and the ability to instigate and persist and make some of these things effective is connected to other things that happen in the organisation and other changes that might need to be made. So at the organisational level, what can we think about? Well, culture matters. The culture of the organisation and leadership, therefore, is really important. And we've already heard about that over the past couple of hours as well. So thinking about how do we develop cultures where learning and support are central to those, and making it easier for people to talk about the impact of their work on them, but equally creating cultures of learning from near misses and incidents that occur, which also then enable people to feel more secure and safer. Taking break entitlements, we know that in the UK, for instance, nurses often don't take their break entitlements, often can't even find time to go to the loo. So these kind of things as well, developing a culture where, it's okay to take your lunch break, it's okay to take your morning break, except in exceptional circumstances, perhaps, where you really can't do that. And presenteeism, again, this is a cultural thing. It's about expectations, and it's about enabling people to feel that it's okay to take the time they need when they need to recover or when they're ill, so that then when they come back to work, they are well and they're able to contribute better. Perceived organisational support, so how much the organisation is perceived as being supported of us, is very much connected to how valued we feel as a nurse or an employee. And it's very, it's things like, for instance, opportunities to get training, to do professional development stuff, thinking even about things like availability of hot food or access to facilities like tea, coffee making facilities, toilets, things like that, which are actually basic needs, but which sometimes are not actually available or terribly available to staff. And then it might also be about support programs, so the kinds of things that would offer support to people during the working day. But then we also need to make sure that actually people have long enough breaks or have the time to be able to engage with these things. Certainly the experience during COVID that a lot of these systems were set up, but that actually staff reported that they couldn't get away from the wards. And that wasn't just because of COVID, that was a normal thing. And then, so provision of resources. We're working in a kind of a restricted budget context at the moment. We're also working in a context where actually there just aren't enough nurses globally. So our resources are tight, but are there opportunities to think about how we develop and manage processes to make them more efficient, to reduce the burden on the staff that we have, and to enable, but without sort of impacting the quality of the care that's being provided. And then thinking about the impact of shift patterns. And there's been, I kind of have been in party to and on the fringes of a lot of discussions about shift patterns over the years, but nothing seems to have changed. And there continues to be a lot of evidence developed around about the impact, for instance, on patient care towards the end of these long shifts, but equally on staff well-being. And, given that the nursing workforce is primarily female and that women are most often the primary caregivers for children or for older people, then flexibility in shift patterns might well facilitate well-being of staff and staff retention. And then thinking about sort of higher level yet, things that we might do. And I talked about the discourse and the tensions between the two discourses. And I think even an acknowledgement of the tensions that exist within the mental health system between the two risk and therapeutic discourses would enable discussion to begin and to start in that space, and the potential for then looking at how do we bridge that gap or reduce the tension or the gap. What kind of policy or innovations need to happen to begin this? But without acknowledging and again, without engaging with these discourses, it's not easy to move forward from that. And then pay and reward. I think it's really important that nurses are valued by being paid a wage that makes them feel that they feel is realistic for the job, the work that they are doing. And within the UK, NHS charities, so charities that are part of the NHS trusts and NHS boards, so usually provide money for patient-facing research or services, they're setting up food banks or already providing food banks for NHS healthcare staff. And in 2023, there was a statement to the House of Lords in the UK that reported on a survey by the Covell Nurses Trust, which had found that 14% of nurses and health workers were using food banks to feed themselves and their families, and nearly 70% were either unprepared or very unprepared for a financial emergency. So I think there's evidence that this really needs looked at. There's also been some sort of political action as well, but in terms of strikes and things, but there has not been necessarily the moves required on that. So these are the actions that I think we can take, some of them individual, some of them organisational, and some of them are things that we need to advocate for and push for through policy and changing in discourse, and looking and examining things that likes of the mental health legislation, for instance, that we use. So I'm aware of time. Just quickly then to conclude, the challenges to mental health nurse wellbeing, I think, are multifaceted and they're interconnected. So this is a complex issue. It can't be resolved by actions by only one or two specific groups of stakeholders. It requires action at different levels to be taken by different groups of stakeholders. I don't think it's impossible, but I think it's something that we need to keep pushing for and we need to keep working at. Thank you.
Thank you very much, Rosie, for a great presentation. As I stated previously, we'll just move into the next panelist discussion or presentation, and then the next, and then we'll have a joint Q&A at the end. It's my pleasure to introduce our second panelist, Dr. Victoria Smye. Victoria is an associate professor and director of the Arthur Labatt Family School of Nursing at Western University. The goal of her research is to promote health equity, focused in the areas of mental wellness and Indigenous health. Victoria completed research. Her completed research includes studies of the wellness narratives of Indigenous women and men, and the examination of those factors that both facilitate and challenge people's ability to access equitable, safe, and effective healthcare. Currently, she's studying how to promote equity-oriented mental health, healthcare, culturally safe, harm reduction, trauma and violence-informed care within and between mental health institutions and community agencies. Victoria is also a mother of 3 and grandmother of 6. So welcome, Victoria, to the panel discussion. I'll turn it over to you.
Oh, hello. Thanks, Don, for that introduction. And it's really wonderful to be here today. I'm hoping you can see my, my slides. Thank you. And thank you for the invite. Been a mental health nurse now for, well, almost 54 years. So that really does date me. And I've loved really almost every minute of it. So it is really great to be here. First, I'd like to acknowledge that Western University, where I'm sitting right now, is located on the traditional territories of the Anishinaabe, Haudenosaunee, Lenape-Wauk, and Adirondack peoples on lands connected with the London Township Treaties of 1796 and the Dish with One Spoon Covenant Wampum. So this place is now home to many diverse Indigenous peoples, and including First Nations, Métis, and Inuit peoples. So thank you. I'll continue. So this is a presentation I come to today really as a nurse researcher, educator, and administrator at this time after spending my first 20 plus years in nursing and clinical practice. And so this has been a kind of a new career over the last 25 plus years. And so I do speak with that voice today. As Dion mentioned earlier, and I'm using the same, I haven't spoken to Dion, I really haven't, but I'm speaking with the same kind of imagery, which is we need to put our mask on first in order to take care of others. And Rosie, I really appreciated your presentation because and providing the contextual features of what we're kind of our challenges, what we're dealing with, and then some of the ways in which we can move forward. And so I would start with our self-awareness, tracking our own feelings, thoughts, needs, and influencers. And that is taking care of self first. And my own ways of doing that are multiple. I have wonderful colleagues, which I show up here that I'm hugging because they are very important to this presentation because of the work that we've done together and also our longstanding friendship. So our relational engagement is hugely important to me. Yoga. I used to be a paraglider, but not really a serious paraglider. Colleen Varco got me into it, and I'll speak about Colleen's work a little bit. But that was very healthy for me, contrary to what people might think when you're flying off a mountain. But it was very, very helpful to me and healthy for me. I work out, and I have a fabulous family, so I'm very fortunate. So I'm going to begin by talking about this social justice and mental health nursing, because for me, it is my belief that nursing's social mandate for the 21st century is health equity. And so we start with that social justice mandate, health as a human right, with a focus on health outcomes as an object of social justice. And this really important shift from an individualistic approach, which we've talked about a lot today, towards these actions that are organizational or structural, systemic. So to pointing to those intersecting factors that are the conditions that really do impact health. These conditions are historically and socially mediated, as we know, and they impact health and human suffering. And I'm going to mention a couple of the challenges of this work that I'm just going to change my little thing here because it's getting in my way. I can't see. So housing itself as a basic right and human requirement for good health. This is such an important area in mental health. So it has been one of our challenges because it's a huge organizational challenge, because the people that we work with need resources, and often those resources aren't at the tips of our fingers. There are two trends that are largely responsible for the rise of homelessness over the past 20 years. In Canada, and that is a growing shortage of affordable rental housing and a simultaneous increase in poverty. And here in London, we have a very strong anti-poverty coalition with the belief that poverty needs to be eradicated. Some people roll their eyes. That's absolutely impossible. I actually believe that the scarcity discourse or narrative around this takes us from our focus, which should be organizational, systemic, structural, and moving resources to places where they need to be. I really don't. I said this earlier on the chat. I don't buy into a scarcity narrative. We move money where we have value in our governments. So we know that people with lived experience of mental health and addictions conditions are disproportionately affected by homelessness. So that's one of our challenges. So if you look at these statistics, this is what's been happening in Canada over the last several years. And I don't know whether that's the case where you are, Rosie, and others, but it definitely is the case here that there is a growing problem of homelessness. And despite our research linking mental health and physical health to housing, there's too often a kind of decontextualizing of the problem, and that lands on the people who actually are homeless or living in near homeless situations. The other thing that comes in here, and I just want to point to it on the side here, is that in an Indigenous context, this is often many Indigenous communities, the medicine wheel is used, and this is one rendition of the medicine wheel. So there's a real integration of mental, emotional, spiritual, and physical health. I think all of us here believe this, but our systems of care don't necessarily embrace this. And as such, our services reflect kind of a disconnection from, for example, housing and mental health issues, poverty and homelessness, etc. And then, of course, I'm just mentioning a few challenges here, but also mental health stigma that we're very aware of. So this little quote comes from a study in which was one of my first studies, where I was interviewing an Indigenous man who was also diagnosed with HIV. He was Indigenous. And so his point to me was, I've already got all these other things. I'm not going to go and be labeled as having a mental health issue also. He already felt very disempowered by our systems of care. And so he didn't feel safe there. In addition, biomedical approaches to mental illness tend to sometimes be deficit focused rather than strength strength-based focused, and not people-centered necessarily. I mean, all of us understand this, but when we're making changes, we're often not looking to the institutions and structures. Instead, we're looking to the individual. And so what our research has really stressed is that that we need to be looking more broadly at these systems and structures in an ongoing way. Yes, individual factors are really important, but unless we do that, we're missing the mark. And I think many of you have talked about that in relation to the care of nursing itself, to those systems and structures that keep us in a place of overwork, discussions about shortages, etc., that impact our lives and our work. So people often think about health and wellness in terms of physical health, that is healthy eating, regular exercise, sleep, etc. But I'm sure, as you know, it's so much more, as we know from our own lives as nurses. It's health and wellness are often attributed to lifestyle and a personalized approach or choices regarding living life in a way that supports achieving our potential. Although this is really true in many, many ways, it ignores the contextual factors that also shape health and wellness, including inequity, that we all have talked about today. In this presentation, I presented what I've learned from my research regarding the importance of addressing inequity to support healing, health, and wellness, and the important part each of us can play to do this, ways that support our own well-being. Our transformative agenda is underpinned by what we learned in research. So first, we all know the difference between equity and equality. And so I'm just underlining here that health equity is the absence of avoidable or remedial differences in health among groups of people. It is not equality, it's rather equity. And we can address inequity in our society. We have the skills and we have the abilities to do this. The research, is just a few areas of research in which we came to the equity work and built on the equity work together. And so some of the studies that I've been involved with are listed here, but I would like to underline my colleagues that have really shaped my own perspective and some of this work, Annette Brown and Colleen Barco at UBC, Marilyn Ford Gilbo, Nadine Wathen here at Western. Patria, I see her here, and I'm just so happy to see you, Patria Taylor in New Brunswick. Other people like Jill Muxlow, who's done tremendous work in this area. She's also here. And Charlotte Ross, a colleague and student that now no longer a student for many, many years. That's how I met Charlotte, and just the tremendous work that you're doing in this area. So the key dimensions, what we came up with through the research and through decades of research, actually now, the work of Colleen Barco started way back in 1995, where she was really looking at those factors that actually shape inequity. And then we moved to the key dimensions, looking at the key dimensions of equity-oriented care by looking in primary care at clinics that were offering services to both Indigenous and non-Indigenous folks. And we came up with, over time, and the research, 3 dimensions, key dimensions of equity-oriented care. So care that needed to be trauma and violence informed, harm reduction, and what we're more recently calling substance use health, and cultural safety, anti-racism work. And these are tools developed into tools for us to help actually address inequity in our work, and for my work in the area of mental health. So one of the 10 strategies here are explicitly committing to equity, developing supportive organizational structures, policies, and processes, which have been mentioned several times today, re-envisioning our use of time, attending to power differentials, including power differentials between staff, nurses, leadership, etc., Tailoring care programs and services to local context. Every community is not the same. Actively countering racism and discrimination, stigma included, mental health stigma. Actively seeking input from community partners. I only do my work in partnership, as do my colleagues. Tailoring care to address interrelated forms of violence and enhancing access to social determinants of health. And again, and this one on the bottom is actually very important, optimizing the use of place and space so it is culturally safe. And what we found in the equity, one of our studies that was a longitudinal study with 395 patients called the EQUIP study, we found that there is a pathway between equity-oriented care and better patient outcomes over time. We also found that it was way healthier for the people working in those environments. And so, you know, we saw that quality of life measures, quality of life improved. There were fewer trauma symptoms. There were less disabling chronic pain and less depression. So we really saw that equity-oriented work really did work. It has great potential in our environments, and created all kinds of tools, because what nurses told us was that they needed to have tools to use in their work. They needed to have tools right at their fingertips to be able to work in a good way with their clients. And again, it not only helped the people they were working with, but it helped themselves to be able to resource people in these ways. And these resources in my reference list, there's the EQUIP site is there, and you'll see all kinds of fabulous resources as action kits for organizations, for example, to look at how they might shift to become more equity oriented. That is trauma and violence informed, culturally safe, and embracing harm reduction / substance use health approaches. And again, these are a bunch of things. There's learning tools, there's action tools, there's evaluation tools, all kinds of, even an equity walkthrough. So the equity walkthrough is a tool to help people walk through their organization to see the ways in which they might actually change the environment in which they're working, change the structures in which they're working. In one of our studies, I was a facilitator, and actually in one of our organizations, people wanted to look at their harm reduction policy and actually shifted their harm reduction policy. That led to the shifting of a room where they provided methadone maintenance treatment to folks. And it was just a terrible, shabby room. And people originally were kind of like, well, you know, this room is, you know, people come here from the street, it might get ruined, etc. But they took this up, they shifted the room, and there was such a response by people to the invitational approach that was created in this environment, the way in which people were addressing just even the space, the time that they took with patients, etc. It made a difference. And here are just some of the tools, again, that are on the site. I really invite you to go there. I think it's very helpful. It's certainly been helpful to me in my own work to go in and use these tools. And we have taken these tools, by the way, into nursing education and have embedded them within our nursing curriculum. The students find it very, very helpful. We also took the notion of trauma and violence informed care and have been using it as a lens to our whole curriculum. That is, we looked at our learning outcomes. We looked at all of our curricula to see how we might integrate these approaches throughout. This is not a perfect science, and we're not there yet, but we've been working very hard to engage with this work in a good way. I just want to show you this briefly. These men were members at that time of the Dudes Club, and the Dudes Club is a club in the downtown east side of Indigenous men, and these men were part of a study that I was very grateful to co-lead, entitled Indigenous Men's Narratives of Health. So those things that created wellness for them. pointing to the obvious things. Housing, they wanted to have safe and clean, comfortable housing. They wanted food that was, nutritious food, etc. They wanted each other. They wanted to have connections with each other. So the messages from the work, the equity work were, in that particular study, was safe and stable housing, healthy food is a priority need. These are structural issues. These are system issues. These are the things that Paul Farmer points to, that when they are not provided is actually a form of structural violence in our society, where people are not given access to these things that we just tend to take for granted. Safe connections with others, including health and social service providers. Culture is healing for people, connecting people to those things that are meaningful to them in terms of their healing processes. Educational opportunities with mentorship, meaningful occupation, including employment and volunteer opportunities. Gender-specific resources, a very important issue, and aging is an important factor. For example, the men could no longer do some of the work they had done as young men, the heavy lifting work, etc. And they needed to be offered employment that they actually was meaningful, both meaningful, but also that they were able to engage with in a good way. And so in terms of nursing education, so my last point, I hope I have a moment. Is that okay with you, Dawn? Am I all right? I just want to say, I think in terms of education, this has been extremely important for learning for myself, as both I was a clinician, as I said, for many years, as a nurse educator, researcher, and administrator. That we branded right away over the last few years. And when I arrived 7 years ago, we decided to brand ourselves in a particular way and live to that branding. And that is to really educate leaders in health equity, nurses who could transform, to be transformative in practice, that the social determinants of health were absolutely essential, underpinning the program and every part of our curricula. That advocacy and voice were huge. They go into the environment, as many of you mentioned earlier, they go into the practice environment, and it's very hard to have a voice as a student nurse. Everybody knows this. And so it's really about how we help our students to engage in that environment in a good way. That means we have to have strong alliances with our practice partners, which we created, by the way. Siobhan, I just loved what you had to say, and we have engaged now with a one-to-one preceptorship model in nursing in our program across all of the practice experience, except for the first one, which is in long-term care. And just don't have enough preceptors there. But our practice partners have worked with us in very close partnership to make this a reality. And so far, the data looks very, very good. So it's both a great experience, not only for the preceptor, but for our students who have a sense of belonging in that environment. And also it gives us an opportunity to together deal with the systems and structures that can be so oppressive. And so we're building this together with our practice partners, debrief sessions, and that opportunity for the theory practice nexus conversation. And again, working in partnership. And I am a researcher, and so here at Western, we really have been working with students to look at ways in which we can build research more fully into undergraduate education. Of course, it already sits within graduate education very fully, but undergraduate education, they do get research, but we need to embed it more fully so they have some more tools, again, for being able to shift the conversation, shift the culture, and get people excited about nursing again. I think that is just about it, other than to say, for myself, and going back to my own self-reflection, my nursing work and everything I do now and for many, many years has about living with compassion and kindness. I'm not perfect in this. To have a just society, we need to realize human rights, leaving no one behind. No one. That includes us as providers. That the central promise of the sustainable, it is a central promise of sustainable development goals, and everyone should have enough food, quality of health, care, and education. all kinds of discrimination must end, and daily life is where a just society begins. So there are a few things you can do. Stand up for gender equality, teach children about equality, sponsor a scholarship, fundraise for schools, support a food bank, model self-care, advocate for quality healthcare, understand and help reduce mental health stigmas, champion accessibility and inclusion, know your rights. A world working together is a healthy planet. And I just want to say that this work energizes me. It is also part of my own healing and well-being. So thank you very much.
Thank you very much, Dr. Smye, for an excellent presentation. Our final panelist is Carissa McEachern, doing a presentation titled Tools and Techniques to Augment Nurses' Well-Being as Members of the Critical Care of the Circle of Care. For the past 14 years, Carissa has been employed with the Occupational and Critical Incident Stress Management Program with Health Canada. As an assistant coordinator, she works nationally with mental health professionals, nurse managers, practice consultants, and frontline nurses to deliver healthcare services focused on nurses' well-being. This frontline service allows for immediate support, maintaining mental health, and contributing to the retention of nurses working in First Nations communities. She also enjoys working with the corporate services branch, mental health team for Health Canada on a second secondment, supporting public servants' mental health by utilizing evidence-based care practices. So welcome, Carissa, to the panel discussion. I'll turn it over to you.
Can you hear me?
Loud and clear.
And can you see my slideshow? That's the important thing.
Yeah.
And then the last thing to ask is right here, making sure that it is running properly. Good. Oh my gosh. Thank you so much. It's always a difficult. I feel like I'm with Rosie when she talks about technology and doing presentations and the different media platforms that are out there when we share our presentations. So thank you again. I think everybody has just leaded me into my presentation because how Siobhan was talking, Rosie, Victoria talking about peer support. That's this program. This is a peer support program. So I'm just delighted to be able to present on our service lines. And as mentioned by Dawn, that it is for nurses working in First Nations communities nationally. So again, if a nurse that is on the line isn't from one of the communities, but it still applies. Peer support still applies, as Siobhan is speaking to it. They're looking out for your own EAP services and seeing what that is what is available. And the other thing is that, yeah, I'm going to be talking about the wellness again, individual wellness as ways that we can develop. So awesome, thank you. I'm going to refer to Occupational and Critical Incident Stress Management as OCISM for short, for the just it's a long it's a long title. But first I would like to acknowledge where I am. So I'm here in Winnipeg, Manitoba. I'm gathered on the ancestral lands and Treaty 1 territory for Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and on the homeland of the Métis Nation. So thank you for inviting me. Health Canada, Occupation, OSISM, EAP service, and this is where I am speaking that it is any nurse working in the communities and First Nations community. It doesn't matter if it is a mental health nurse, and congratulations on Mental Health Day. You guys are awesome. Thank you for the work that you do. And then going back to the nursing, it doesn't, the mental health nurse, it can be an RPN, LPN. Indigenous Service Canada is the federal government that goes into the communities, and agency nurses go there, and there's also band nurses. So this has been around since 1991 for the nurses. It started in Manitoba because at that time they wanted to check in with the nurses working in the communities and seeing what types of stressors they were actually experiencing. And at that time, they saw that 33% were experiencing PTSD signs and symptoms. So the federal government was like, okay, what can we do? What can we do to support the nurses? And that's where this program was developed. It also, at that time, well, let's fast forward a little bit. It's progressively gotten bigger on the services that we can provide. Back in 91, that was looking at just critical incident stress debriefings. So again, Siobhan, yes, we need it everywhere. We need these debriefings everywhere. So yeah, it was at that time that they were looking at just a critical incident, but fast forward, we're now today looking at, of course, it's not just critical incidents that affect nurses. It's the cumulative stressors, where Rosie was talking about burnout for nurses. There's different type of compassion fatigue, vicarious trauma, so many other things that were kind of missed, I would say, and that are more forefront right now. And so now we can provide some more services, and it's excellent. And I will talk a little bit about that. And wellness strategies. I think that we all have spoken on this topic, but I'll just give my little lens on how we approach it and how we've been supporting the nurses. And then I'll just look at a couple other resources that are available to all nurses, not just the ones working in communities. There is definitely some other resources available if there isn't in your EAP employee assistance program through your own benefits available to you. All righty. Here we go. Our OSISM goals. This can, again, I was invited to talk about our service lines, but this is definitely can be for anybody and individually looking at the impacts of workplace stress. This is one of our goals, the primary prevention. What types of stressors are affecting nurses, and what can we do and provide the tools and information and in order to look at their own resiliency against stress. So how can a nurse build their own resiliency? Well, first and foremost is the education and ways on how our own bodies are affected by stress. I know that Siobhan, there was some conversation around the stiff upper lip, right? There was just some discussion during that presentation and in the chat. For me, the one thing that I would say is that healthcare professionals then and now are seeing ourselves that we are not just the healthcare professional, we're human. We're human beings. And what's that mentality of the stiff upper lip, or I've heard the cringe of suck it up, suck it up, buttercup kind of thing, that type of mentality can come from a place where someone feels that they're the healthcare professional first and not the human being, and that they are not to respond to these types of things. That's, it's just part of the job. Well, no, it's a normal reaction. And I think I'd be harping on to talk about the fight and flight freeze response, right? You can't deny that as a human being. And that's yeah. So I just, that mentality, I think is since I've been here for the last 14 years. And before that, I was 5 years nursing in First Nations communities full time. And previous to that, I was born up north, so I'm a northern girl. So it just my life has brought me here, and to be able to support the nurses that I understand those challenges that they're having. But I have seen a shift. I really do believe that stiff upper lip has changed, that we are seeing that we're human beings. So, and secondly is the early support services interventions. And through our program, we do have the debriefing. We do have cumulative stress coaching, resiliency coaching. And I'll speak to that in a moment. And then obviously is to accelerate the recovery of for the nurse after an event. Briefly talk about the different areas of occupational stress injuries, because I know this has been brought up already. Critical incident stress, how we define it here in OCISM and through the our program, is an event that has occurred on you at your job that has caused strong reactions which are affecting you at the time or later, where it's affecting your work. For example, I would say that you're having intrusive thoughts, and the next, or maybe 2 days later, you're seeing a patient, but you can't stop thinking about that event that happened. That is affecting your work, right? So we want to be able to support you in any way possible during that critical incident. How we get a hold of nurses, I should just mention, after a critical incident, is that the federal government is set up of receiving occurrence reports from communities led by the nurses, and that gets sent to Indigenous Service Canada to let their managers know what has happened. It can be from faulty equipment to something more major, a death, for example. And we're a piggyback system where that occurrence report gets sent to us, and then we make a proactive phone call, because we know nurses are not going to call all the time. So we make that proactive phone call to check in. And I think I heard that in previous presentations too, is like another check-in. How are you doing today? How that's a hard one. How can I help you, right? So that's after a critical incident. And we know the other ones: vicarious trauma, repetitive, the same event being noticed, and where it can change your world views. Definitely it can affect us because of the work we do. Compassion fatigue, the empathy, right? That heavy heart can be affected. Moral distress, we're hearing it more in literature, but it's definitely not, it has been something hasn't happened. It's just because of our current events that the moral distress is being seen more often. And for what I've been involved in, it's around the short staffing also, because not being able to see everybody, or it's been at the very beginning of the pandemic, who gets the bed, who gets the vaccine, all of those distressors can definitely play on the nurses. Conflict in the workplace, job stress and burnout, normal reaction to ongoing workplace stressors. I'll just mention a stat that has come out in 2020 through Canadian Federation, that 80% of nurses have experienced a critical stress reaction, which is huge, right? In Manitoba, in 2005, they did a study, also Bell Let's Talk Canada. Some of you may be familiar with that. And they looked at what types of critical incident stress reactions were being, what were the causes. And the top ones was short staffing, death of someone you know, and death of a child. So that was the three major ones that were seen as critical stress response in healthcare and in nurses. And this is where I kind of like to look at where we are human and we are unique, right? So we all have these internal and external factors that come into play when we're in an event. Our personal history, our family history, how we've coped with things in the past, the nature of the incident, and our social support's big one. And I think that's been spoken to, peer support, social support, right? Where I understand those challenges that nurses are experiencing. Your colleagues understand what you're going through. Having that network of social support is huge. I've seen nurses that have gone through really tough events, but they said they had a good team. You know, they had the support from their team, and that made a world of difference for them. Work environment, the training, the role clarity, management support, of course, a big thing, right? That's the management organizational support during an incident, and access to the diffusing and debriefing. There, you can be triggered for sure in other events, but when we're looking at timely diffusing, our hope for OCISM is definitely to get a hold of them within the first 72 hours after an event, just to check in. Because as we know, the longer it goes, the development of PTSD after a month, right? So there definitely is that timeliness that we want to reach them. I just wanted to throw in this slide because, you know, there was a time that people well or unwell, and we know it's not stagnant. We know it's not stacked. Like we know that there's ebb and flows throughout the day. But we go from this continuum of green to red back to orange, yellow, throughout our day, throughout our life, and just recognizing that and checking in with yourself daily. How am I doing today? Where am I at? What can I do to different types of strategies, our tools and our techniques that we can incorporate into our daily lives. And many have mentioned different types of holistic approaches that we can do for ourselves and our well-being. Just mentioning around workplace stressors, just different with them. This comes from the mental health continuum that they look at it as mood, attitude, behavior change, and physical changes. So just to throw that slide in, just as an opportunity to see that there is different signs and symptoms when we're moving through this, from languishing to distressed or back to thriving or flourishing. ultimately, what we're trying to do is build this big luggage of different types of resources, tips, techniques for when we need it. And the one thing that I would say is we need to develop it before we're in that situation, right? So we need that emergency plan before we are in the emergency. There's different plans. There's like the daily plan. There's like maybe a booster plan where I just need to take a breath, or there's the emergency plan. So how are we building and coping with these stressors and hardships, right? So knowing that resiliency can be learned. I won't mention a lot on this slide because I think that it has been kind of addressed throughout the different presentations. I'm just putting it in a different wheel where we're looking at the different aspects of our own unique lives and what can we do to incorporate different areas. So professionally, taking our breaks, and personally discovering our goals, looking at our self-awareness, our purpose and our passion, psychological, looking for support groups, looking for counseling, spiritual, that was mentioned prior. I find the joy in daily tasks, right? Discovering our cultural identity. Nature is definitely is seen as a spiritual for some. And again, I think I heard church and religion as another spiritual way. So really looking at who you are and the tools that you're going to put in that toolkit or that luggage bag. Self-compassion, our different types of mindset. We just heard from Victoria talking about safe housing. Thank you. Like that's another thing that is missed when we're looking at our own uniqueness and to develop that. Social networks, our own emotional intelligence. So just another approach to look. For those in the audience that are working in First Nations communities, I did want to mention the different types of programs that we do offer for OCISM. And the first and foremost is that proactive phone call. So what we're doing at that time is assessing and diffusing, going over not necessarily the event, but going over how it is feeling for you, how are you dealing with that event. We usually do a follow-up the following day just to see if symptoms have subsided for you. And if they are continuing, that's when we offer the debriefing service, and that is the critical incident stress service. So that is something that we do have throughout nationally. We have mental health professionals that are available to us through our own employee service program, through the federal government. And we would connect the nurse with that MHP. The other types of services is cumulative stress coaching. That is the combination of occupational stress injuries. So we do offer 4 sessions with that service line. If there is needing ongoing, all of these are, if there is more that is needed, for sure, we're going to provide that service and look at how we can support that nurse. There's resiliency coaching. Whenever I look at resiliency and cumulative stress coaching, the difference that I say with those two is that resiliency, we're really looking at setting a goal up, and you're more in a green-yellow zone, whereas cumulative stress, there's some reactions happening because around occupational stress injuries, and you're more in the yellow-orange, and we want to get you back to the green zone. So that's kind of like the differences that I see with those two programs. And then we have me as an assistant coordinator, and I do have other colleagues that we have bilingual nurses, assistant coordinators on staff too, as the peer assistance line, or we do call it well-being check-ins is another way of looking at it. And we can, with that one, we provide support calls to the nurse monthly, as a friendly ear to talk to. And we might at that time see that we might offer one of these other service lines. Yeah, so there's different approaches that we do have for the nurse. Lastly, I talked about the emergency wellness plan. Set that up way before you are an event that it requires, because it's really hard to think of what to do when you are in more of a crisis, and setting it up, what to include, and that's that wheel, or at what others have spoke about in their presentations. That was just wonderful. And okay, so lastly, different types of things for nurses, all on the phone. Wellness Together Canada. There's immediate tech support for the nurses, right there. Hope for Wellness for Indigenous peoples across Canada. They also offer language Inuktitut, Cree, Ojibwe as a counseling service, so that's wonderful. Before operational stress, BOSS, that is something that is offered through BC actually, and it is a resiliency coaching program that is self-led. Life Speak is through the Government of Canada, and just put in that password Canada, and you're going to have a whole slew of podcasts, meditations, workplace wellness, like just tons of information. But for those that are specific, that may be working for Indigenous Service Canada on the line, there is Center for Integrity of Values and Ethic, or Conflict Resolution. Oh, those big long sentence titles. And then ISC, Indigenous Service Canada, EAP, Employees Assistance Program. That's how you get a hold of me or one of my colleagues, is the EAP. You just ask for OSISM. The 1-800 number is there for you. And if you want to, you can put your phone up to that QR code, and yeah, and let me know how I did as I ran through it. Thank you. I hope that is clear as mud.
Thank you, Carissa, for another excellent presentation, as from all of our panelists. We can now open it up, though, to the floor for any questions to Rosie, Victoria, or Carissa. I would like to bring just the attention to one comment that came earlier on that was posted into the chat during Rosie's presentation from Charlotte Ross. It was just saying, thanking Rosie for contextualizing the prominent individualized or individuated neoliberal emphasis on resiliency, and how your comments were aligned with or parallel to some of the findings that she had in her study that was being published. So I maybe give Charlotte, if you're on, and my apologies for not giving you the opportunity to talk about your publication previously, because I think it's very relevant to the discussion here today. But maybe I'd give you the opportunity to tell us a little bit, without sharing too much about unpublished research, just a little bit about the project and maybe how it's aligned with some of the stuff that came out today. So, Charlotte, are you available?
I am. Thank you. I was just thrown out by my computer a little while ago and lost all the chats. So if anyone sent me any notes, I didn't get them. But thanks, Don. I certainly didn't expect to talk about my research, but yes, I did notice with Rosie, I did put a note up there of how some of the comments that you made in your presentation contextualize the problem. And I found that and the same with Vicky too, Vicky Smye. In my research, very briefly, it did, what the nurse elders did believe that student nurses needed to learn was broader than the current discourse that I've read in the literature, which is quite individuated and decontextualized. So sorry, I wasn't prepared to present this, so I'm just trying to think of the important points. But there are three spheres. One was the individual sphere, which is self-care, all those things we know, but some really important ones that we don't talk about, like specifically how to make a line between your work and your home life and why that is important. The other thing is the other two spheres was the peer realm and how important it is to for peer support and to learn how to be a good peer as well. So that mutuality and the loss of the important mentors in our system because of the systemic issues, the loss of managers from direct care that we used to have in the Stone Age, who were our mentors. So mentors in our direct work are lost as well because also the workload isn't supporting mentoring students. And the other thing that Rosie and Vicky alluded to was that organizational realm and how important advocacy, self-advocacy is. And that came out too. The elders said that that we need to build capacity in the students to not only learn how to manage the emotional labor, but learn how to advocate for psychologically and physically safe working conditions. So lessons learned the hard way. So I put out a call just in British Columbia for participants and a qualitative study, and I got 688 responses. Yes. And I saw your mouth there, Rosie. I'm not turning on my camera because I had no attention to my grooming whatsoever today. So I think like 80 or 90% of them were over the age of 60. And many of them were saying, we have so much to contribute that is lost. So anyway, that's nutshell, but Rosie and Victoria did, that decontextualization that my data showed as well, that the nurse elders had stated. Anyway, so that was sort of a quick nutshell, best as I could do.
No, thank you very much, Charlotte. And maybe I'd ask any of the panelists to respond to anything that Charlotte added here. Victoria?
Oh, I was just thinking that I was thinking about a conversation about students, and one of my faculty was saying to me, these students, they're so aggressive about their needs, and they're so this generation, right? And and I was just like, I had to think about it for a moment, right? I have to admit, I was like, well, let's grab hold of that voice then, because if that voice goes into practice, in my day, if we spoke like that, it'd be, here's your hat, what's your hurry? And I was like, no, that's not what we want to do. We want to open the voice. We want people to stand up for things. And yeah, sometimes it's not reasonable, but we have to have the conversation with our students, and they're so smart, man. They run circles around me. And I was like, let's celebrate that voice and encourage students to stand up in our environment here in the educational sphere and make it safe for them to do it outside, because believe me, that's not a safe environment necessarily. Students talk about power relations, and it's big in the environment. So, you're a student and you're now being precepted, so you immediately don't have as much power as the other people, right? And so it's also about just helping in a debrief conversation, helping students deal with those things and moving forward. So that's what I would say to it, to what the elders said about it, because voice to me is just hugely important. It comes up every week, by the way, that somewhere they needed their voice and they had trouble using it. They also have to be bystanders to bad conversation, stinking thinking, and they're expected to be transformative. So we talk about stinking thinking and how they can help to create a better conversation, a different conversation. So anyway, I just wanted to say that, and the students are marvelous. I marvel at them all the time. So.
Thanks, Victoria. And Dion had her hand up. So Dion.
It's similar to what was being said, but this is towards Rosie's presentation. And at one point, Rosie, you said about the nursing shortage, and it's like a global nursing shortage. I did my master's looking at IENs and looking at poaching from other countries. And when I looked at the data, there's over 500,000 registered nurses in North America. However, because they're not feeling valued or appreciated or not being treated well, they're selling cars, they're selling houses, they're stay-at-home moms, they go off, some are driving truck because they'd rather do that. So when Victoria is talking about a message and the discourse, leaving the profession is sending a message saying, I'm done, I'm out of here, and I will go be a, used car salesperson. And so there are plenty of registered nurses. If you look at the amount graduating from schools and getting registration, but in 1 to 2 years, because of ill treatment or poor leadership and just a horrible toxic work environment, they're not staying. And my own daughter, love her to death, full-time job she had at St. Mike's, and they refused, wouldn't even consider giving her a time off that she needed. Oh, Mom, I just quit. I go, what? You did what? We would never, ever think of doing that. She got another job right away, but would never, ever think of just quitting. Well, nope, they refused to even consider it. How can they not even consider? She's out. And it was, whoa, never. So there are many, 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 many nurses out there. We need to start treating them better or they're not going to stay. And I'm worried because I'm getting old and I need someone to look after me. So we have to start treating everyone better.
And there's some support for your comments, Dion, in the chat, that this generation has a very different take on employment and voicing their needs. So this is very relevant. There was also a comment, and Cindy, to not put you on the spot, but there was a question to Rosie about presenteeism in her presentation, and just the opportunity to maybe talk a little bit about presenteeism and its impact into our greater conversation here today. So maybe, Rosie, I'd give you the chance to respond to that.
Yeah, I mean, I think the issue that we're aware of within sort of our context is kind of, I suppose, really what I put in the chat. It's the problem of people feeling guilty because we have these staff shortages. So the areas are really short. Staff are really, some of them are really, really stressed. They're overburdened, but we also have people turning up still when they're really quite ill and or not taking time to recover when they have been ill, so they're not coming back at full capacity for working, and the problem that creates, I guess, is the psychological issues for people about not feeling able to take that time off. It rescues organisations because organisations are being allowed to continue as is because actually the individuals are taking that strain. And instead of organisation is actually dealing with, again, something that is an indicator of a problem within an organisation. And I don't mean just sort of a hospital, but maybe sometimes it is more localised than others, but I'm really talking a systemic issue that we have here. So, and I think, I think a number of the issues that we have with organisations as systemic issues, I see them also quite gendered. So they're about women, they're about emotions, they're about actually being really supportive of your colleagues and the connections, the social connections that you make and not letting people down. And I'm not saying men don't do that. But I think actually the organisations, they get away with it partly because actually it's, and I'm making a huge generalization here, but it's slightly a gender thing, and it is, you know, I think women are more prone to all of these ways of keeping things going at all cost, particularly because patients at the end they know will suffer. And so it's you know, it's about their colleagues, but then it's about the patients, and it leads to a really unhealthy cycle. So there you go. I didn't know I had so much to say about it, but that's kind of where I'm at with it.
Thanks, Rosie. And there was a comment from Melissa in the chat as well. She works on an ACT or ACT team in Kelowna, and the guilt also applies to letting clients down. So it's not just, you know, the personal guilt, or it goes beyond that. It's a high need clientele served by this team, and it has impacts on the clients if there's nobody there. So I think there's a big conversation here that this is all a part of. I could turn it over to just if there's hands up for anybody that would like to ask any of our panelists any questions. And going to the chat. So how can we push for change in the system so it listens to us? Or and maybe I'd give this one to Carissa. How do you get the system to listen? Or what kind of, is it the message? Is it the voice? Any ideas to address that question?
Oh, wow. That's a difficult one, isn't it? It's the voice. I like how Victoria put it, like an open voice. That's you know, that the generational differences that has occurred now from even when I was going to school. I think that there is more of a voice from students and from leaders that are coming out that they can look at change. I think it's going to their organization and speaking to them about situations where I would feel that in the past you would just go along, right? And I'm glad that there's that shift and change, and the shift in seeing that mental health is mental health. Like, it is just as important as physical health. And I think that's what I see. That's why in my organized with autism, there's value in mental health now. And it's going to the powers of be, or however, within your organization, and advocating for you as a nurse and your well-being in order to keep those nurses where mentioned that they're leaving the field because of not feeling valued, those ones. So I don't know, it's a hard but it's going to the leadership and advocating.
And I see Joe Muxlow with your hand up. I'll turn it over to you, Joe.
So thank you. So my comment is with regards to the change piece. I think so often as nurses, we have not held organizations and leadership in the organization accountable. We have been able to carry the burden at our own expense. And I think mainly because there's always been this fear of being punished if you speak. And even more so if you're a woman of color or a Black woman. But I think coming from a mental wellness, mental well-being perspective, I think it's about time that we look at how do we hold system accountable for the structural inequities that happens at the back of mental health nurses. Some time ago, we had those 13 psychological workplace factors, which talked about recognizing and valuing and civility. And I think one of the big things I think each one of us as mental health nurses, even though I'm retired, is about how do we challenge the system with regards to being so uncivil to nurses who are the backbone of the system. And so I think with the young ones who have the voice, which is kudos to them, it's about how do we build that we don't lose a voice? Because for many nurses within the system, why the change hasn't occurred is because we have lost a voice because we were fearful of what would happen. And so we talk about decolonizing the system, but how do we look at it at reclaiming who we are, and how do we have people in leadership role who will start valuing the contribution that nurses bring to the table and recognize that? Because without that, creating that space where you can thrive and strive, the system continues. And I think we as mental health nurses, because especially the way we've been we look at things, has created that system whereby there is no accountability because of fear of us being, retaliation or punish or those sort of things. So this is 2024. And I think for all mental well-being, we need to, how do we advocate not only for ourselves, but how do we advocate to make sure we reclaim our voice within the system to break down those structural barriers and those inequities that continue today in the name of progress. That's just a comment that I wanted to make. Thank you.
Thanks, Joe. And Stephanie, I saw your hand up. I can give you the floor, and then I can go to Rosie.
Yeah, I just wanted to add that I'm a living proof of how an organization, an environment, when it's unhealthy, how it can impact a person. I began my career as a nurse 20 years ago, and I knew I wanted to be a mental health nurse. So I started right from the beginning there. But my personal life was also going into a torment. I lost my sister from cancer in that first year that she was in. Being a nurse, you want to be there for your family at that time. And, one person mentioned when you are a nurse in the family, a lot of people expect a lot from you. So I had no support from my place of work. Being a mental health nurse, working in mental health, going through my personal journey of my mental health struggle, they just kept weighing my sick time, just there. Okay, you're doing good, but there's the national average of attendance. I think micromanagement, they need to step back from that. And when I say I'm living proof, when I switch now I'm working, I'm part of the mental wellness team for First Nations communities. So I work under Indigenous Service Canada. And the support, I have 3 times the task load of what I had in my previous job. We all know that the trauma, the complexity of cases is different, but I feel supported and I am better at what I do. We have recognition, we have reward. Our bosses organizes specifically a ceremony to recognize us each year. That makes such a big difference. And it's small things. It doesn't have to be huge. We talk about self-care today. When we did our CISM training for the First Nations communities, we invited the public as well to join us because we feel that when we deal with crisis, we need a community, not just the professional. So we revamped and renamed the CISM and we call it Take It to the Fire, because we're using the culture and the medicines and the ceremonies as well. It's so beautiful to see the things like that, and it's something probably I'd like to see in worldwide, like to include the culture part of it, because it's been so healing for a lot of people.
Thank you. Yeah.
Thanks, Stephanie. Very relevant to the conversation. Rosie, I'll turn it over to you.
Yeah, thank you. That was really lovely to hear, actually, Stephanie, particularly the reflections on the culture and how supportive that is. I suppose I was thinking, in terms of shifting systems kind of on a sort of a macro scale, thinking about actually we need to, but I think there's two things. I think we need to have a united sort of voice. We need to stand together. I'm a member of a union. I think that's really important that actually we have some kind of united voice. And interestingly, when Lorna Butler from your university, Don, New Brunswick, came across and I met with her recently, we were talking about that kind of how do we start sort of shifts in the discourse around about nursing. It was actually around about something else to do with nursing, but on an international level, because there are so many things that are actually the same and similar issues, and yet, you know, so there's, you could have sort of solidarity that we need, I think, on a national level as a group of mental health nurses. And I think engaging with chief nursing officers in the government. There are people in government, well, there's people in our Scottish government and the English government, I'm assuming somewhere in the Canadian governments or in the sort of the more local administrations,
yes,
there are as well, who would be people who we need to get on side and be able to influence. And I think that kind of political engagement can only happen if we're actually doing it as a group of people as opposed to as individual people. And I think, you know, students I think they're much more politically aware. I think the climate crisis means that actually students are thinking about how do we change things? How do we push in? And a lot of the how do we change things, they're using their voice, they're thinking creatively and innovatively as well. And so I think, you know, harnessing them and people who have the longer sort of experience of the mental health service and bringing that together, I think would be really, really strong. So I guess I would advocate for some sort of collectivism, collective action, and harnessing the political engagement of our students and our younger generations coming in, because actually it's terrifying for them. They come in as newly graduated nurses. We're disappearing because older nurses are retiring, and many of the wards are being, inpatient units are being staffed by very, very new nurses, and they talk about feeling quite unsafe in that context. So, you know, there is a need for us to do something and to change these things so that then we don't lose so many nurses, and we might even attract some back.
Thanks for that, Rosie. And I see Jean has her hand up as well. So Jean.
yes.
Yeah, I want to just say that I think it's really, really important that we push, and get the students, you know, a lot of the students are willing to push right now. And they're pushing back and saying, why are we not doing this or that? But we need to be getting the students to push and to think about if they're going to go into clinical practice, they need to push. I mean, they're going to be doing work and whatever, and maybe it's the first time or whatever it is, or a new spot, but we need to be pushing and getting them thinking to work together. How could you do something? What do you think needs to happen? And getting all bodies to work together, because we need to be going, you know, at all levels. And the students are feeling that as their education progresses, that they're learning some skills and they're actually engaged in some advocacy work. That's what is really important, because once they graduate, then, you know, what we're saying, you keep going, keep doing it, keep pushing for whatever is needed. To me, and when we're hearing about the presentations today, didn't matter where anybody was working. Different countries and all over Canada, we're all experiencing the same thing. And it's really, really important that we keep pushing and getting the students to push, and we not accept, you know, whatever's going on. And, you know, back to, you know, power. And, you know, I think it's the power of nursing, and we're talking about, you know, gender as well, but definitely the power of nursing, because very often nursing is just totally dismissed. Oh yeah, you can just do all of that stuff. You know, it's so important that the students as As they're developing, they're pushing back, and we are supporting them in pushing back. I just think it's so important that we just don't let it go. Thanks.
Yeah.
No, thank you very much, Jean, for your comments as well. We're getting close to the end of our time, but I can give the floor to at least maybe one more question to any of our panelists, or if there's any comments that anyone would like to add. Now is your opportunity. And I have also been monitoring the chat. There seems to be some real again great discussions kind of happening while the discussion's happening. So that is excellent to see just the level of engagement. Perhaps this is then a natural kind of ending point then for the panel discussion. I'd like to thank our panelists, Dr. Rosie Stenhouse, Dr. Victoria Smye. I've been probably pronouncing it wrong all day, so my apologies. And Carissa McEachern. Excellent discussion, excellent participation, and overall an excellent education day.